So in its simplest description, a stricture is a scar in the urethra, which is the tube that drains the bladder. And the symptoms typically, as you'd expect, would be slowing of the flow when you urinate, spraying or splitting of the stream. Patients may present with dribbling after they think they're finished, or feeling like they've not completely emptied their bladder. And then ultimately, as the bladder starts to struggle, patients' bladders get a bit overactive, so they may go to the pass urine more frequently, more urgently, and get up at night. And then as things progress further, patient starts to get urine infections, so burning or stinging when they pass urine, and ultimately they may stop passing urine altogether, go into urinary retention. So urethroplasty is a term that covers several operations, and that's based on the anatomical location of the disease, or the stricture disease in the water pipe, so either penile or bulbar. Penile is from the tip of the penis to the scrotum, and bulbar is generally from the water pipe in behind the scrotum and in the perineum, which is the part of the body you sit on with a bike, when you sit on a bike saddle. So urethroplasty is a slightly more complex operation than a endoscopic operation where we simply stretch the scar, and we tend to use urethroplasty when the simple operations fail. So traditionally, in the UK, patients had a general anaesthetic for circumcision, but since the COVID pandemic, when we had less access to operating theatres, we've been doing more and more circumcisions under local anaesthetic, and we set up a clinic in Reading to do local anaesthetic circumcision in a small theatre, in a nice environment in a clinic. We've done nearly 300 cases now. And that's been really well received and well tolerated. So I think half my patients have a general anaesthetic and half would have a local anaesthetic now. So technically, yes, it is a major surgery, but compared to, say, a urethral dilatation. But I try to explain it to patients that urethroplasty is a fairly superficial operation. We, broadly speaking, transplant part of the cheek, the inner lining of the cheek, into the water pipe, into the urethra. And depending on the part of the urethra, whether that's in the penile or in the bulbar part of the urethra, that can either be a 1 or 2 stage operation. In the penis, it's typically 2. In the bulbar region, it's typically 1 operation. Broadly speaking, it takes between 1 and 3 hours. Patients have 1 night in stay. Some people will even go home the same day. And most patients will need a catheter for 1 or 2 weeks. So yes and no, it's a bigger operation than a simple one, but it's not a major intrusive operation, I don't think. So the success rates of urethroplasty are generally very high. People quote 80, 85%. But really the success rates are determined by many factors, such as patients' age. Younger patients generally do better. Patients' comorbidities, so if they have diabetes, if they've had previous radiotherapy or extensive trauma to the urethra, they will affect the outcomes. Body mass index, patients who are larger will have worse outcomes because technically it's more challenging for the surgeon. And ultimately, outcomes will be determined by the expertise of the surgeon. The expertise. Generally, patients should opt for a surgeon who does between 25 and 50 plus cases a year. So in 50% of patients, we never find a cause, interestingly. But other causes would be what we call iatrogenic, so doctors or nurses traumatizing the urethra with catheters or cameras, infections or sexually transmitted diseases, trauma to the urethra from road traffic accidents or kicks, falling on your bikes, bar the wrong way when you're younger. And then some skin problems like we've already mentioned previously, so lichen sclerosis would be common, and some congenital conditions such as hyperspadias can be associated with stricture disease later in life.